So for the last panel of the day, I'm going to introduce the panel host, who is also on our chairing committee, Dr. Tina Hernandez-Boussard, who's also with Biomedical Informatics and Surgery here at Stanford. And I'll have her introduce all the women on her panel.
Okay, so it is a pleasure to sort of wrap up this conference today. I don't know about you guys, but it's just been an amazing conference, and we've heard so many thought-provoking ideas. And we really are the last panel. I know some of the other panelists were marked last panel, but we are the last panel. And I am so excited that we were able to put together this panel. It's an all-women's panel. And we wanted to pull together this very diverse group to kind of talk about, a lot of the concepts that we talked about today, but really thinking about the future of AI in medicine and the framework that we should be thinking about. And so again, a very diverse panel, and we have a short amount of time with a lot of people. So we are going to get started by going through and introducing everyone and getting a little feel for their work. I will start with my own work. So I'm an associate professor in biomedical informatics here at Stanford. And in my lab, we focus on gathering all different types of data. So not only electronic healthcare records, but social media. We look at geocode data. And we also do a lot of work gathering patient surveys. So there are thousands of surveys that are collected throughout the hospital and stored in individual clinicians' data sets. So we actively go through and try and capture this information and see how we can relate that to some of the outcomes we see. We apply all different types of methods to analyze these data, and really it's about transforming the data into knowledge and then trying to bring it back to the point of care. So with that, I will start with going through the panel, and I'm going to have each of you please just introduce yourself and give us a brief overview of your work you're doing and how it relates to sort of what we've been discussing today and the framework of the future of AI in medicine.
Hello, everyone. My name is Marinka Zitnik. I'm a postdoctoral fellow in computer science department here at Stanford. So my background is in mathematics and computer science, but I care really deeply about biology and medicine. So my research is focused on developing user-friendly AI tools that can be then used by doctors to guide their treatment practices, for example, recommending them what kind of drugs should they prescribe to a particular patient that can help researchers developing new treatment regimes or just discovering biology in terms of identifying hypotheses that are most promising for downstream analysis, which then can reduce the resources needed to really validate potential hypotheses, as well as for every individual or patient or that are really curious about their health and how they could improve their healthcare. So primarily the kind of data that we consider or that I consider in research is the data that it comes from molecular biology experiments. So this is experiments that primarily come from model organisms or from clinical trials. And one of the challenges that we see there is really that we need to be very careful when trying to integrate this molecular biology data with some data that is closer to patient populations. In particular, in a recent project, we were interested in predicting side effects for drug combinations. So it turns out that it's really common to take multiple drugs at the same time. They're essentially more than 50% of patients that are 70 years or more take more than 5 drugs at the same time. However, clinical trials or the process of drug discovery is really focused on studying one drug in isolation and what are the side effects of individual drugs. So we were asking, well, given this enormous gap, can we use computational methods to try to prioritize, try to flag and identify what are those drug combinations that might be safe or not safe even before they reach patients? Because otherwise, we kind of are doing these experiments in real life patients without really knowing what will happen if somebody takes 5 or 10 drugs at the same time. And really the kind of challenges that we experienced with that were mostly related to the problems of differential reporting. Just to like, briefly give examples of what I mean by that, it's really the fact that we have seen that certain type of data is derived on a subset of patients that is not nationally representative of entire population. For example, it turns out pregnant women are not eligible for lots of clinical trials. That's why if you use those clinical trials data for really making inference, we might have lots of problems and actually high false positive rate on this class of patients. It also turns out that lots of rates or side effects that are reported in these adverse event systems that are hosted by FDA are really biased towards, for example, certain side effects or drugs that are new or that physicians think they should consider or should get substantially more treatment or substantially more attention. And then we see more data for them, even though they might not be really interested for that. So we can talk more about that later.
Hey, thank you. Hi, hello, everyone. I'm Carla Pugh. I am a professor in the Department of Surgery here at Stanford, and I actually wanted to start my little spiel by admitting one of my strong biases. I have a bias, and it's such a strong bias, I call it a mantra. And I believe that if you are going to create an expert, automated and intelligent system, that you should study human experts. So some of you are thinking, okay, yeah, that kind of makes sense, or I know people who are doing that, and others are thinking, that's a horrible idea. Human beings are incredibly different and do things differently, erratically, and what sense would that make? So that actually is the platform for our research in our laboratory. We have a research laboratory where we build simulated human beings, simulating disease processes, specifically medical disease that is treatable by procedural medicine, whether it's an operation, a bedside procedure, or you're doing a physical exam to diagnose. So we partner with companies. We buy models, we build models of human disease, and then we add sensors. We add sensors either to the model or to physicians, and we put them in a critical decision-making point in their area of expertise. And even though I'm a surgeon, I've done this with family practitioners, OBGYN. I don't discriminate on the clinical area. My interest is really, how do you quantify clinical expertise? And over the past 17 years, we've built over 27 different clinical models. We've collected data from over 17,000 physicians, and it's addicting. What we did, I think, and I'll sort of tell the end of the story, we've given one of our data sets to an expert in haptics at Carnegie Mellon. And she did something different with the data than what we did. We were mainly looking at this expert signature and profile. When you look at those who are accurate and have the best outcomes in this simulated environment, their force profiles and movement profiles all look the same. And they're shocked because they're convinced that, well, you know, I'm an expert, I do it differently than so-and-so, and you're never gonna find anything, we all do it differently. When you look at the data, they all look the same. There's very specific metrics in terms of the force they use, how they move, when they're not moving, it looks the same. So we gave this data set to one of our data, very specific data set for the clinical breast exam, to this haptic expert, and she took it to the next level. She looked at those who were accurate and had the best outcomes in half the time. She was looking for the Olympians. Is there, above and beyond this profile that you have for those who are accurate and have good outcomes, is there an expert profile, one, you know, where they're more proficient? And there was. It was very interesting. So similar profile, but then there was differences in the movement and the force. Then she did something else. She looked at gender. And that was not an area of my research, but the results were interesting. The male Olympians of medical procedural skills have different force profiles and movement profiles than the female Olympians. So we're not talking accuracy, we're not talking who does it right and who's the best. These are the people who are at the top of their game and they're doing it better than their colleagues. And the force profiles for the male and female Olympians look completely different. And so then I thought about that with respect to diversity and inclusion and data. And the reality is we have really one curriculum and we have really one model of expertise. And I openly admit, as a clinician who trains doctors, I teach to that one model. I used to. This data is hot off the press. Now I'm thoughtful about it. I think there's some opportunities there. And so when I think about a platform, it makes me thoughtful that, similar to other ways of quantifying expertise and us doing the research and understanding what expertise looks like and defining that, then there's another variable, there's more data. There's some opportunities there to add to the psychology and the sociology and other profiles that we understand about expertise. We can add some data to that. Thank you.
Hi, good afternoon. I'm Allison Pugh. I'm a sociologist. So in this company, I feel a bit like, the zebra. And in a little way, today is also data gathering for me. That's because my work focuses on relationship. Specifically, I'm interested in a relationship across multiple occupations. For today, I'll talk about my interests in the doctor-patient relationship. And I've been doing this research for about maybe 3 or 4 years. I've interviewed and observed hundreds of, or more than 100 people, practitioners, administrators, and engineers, because I'm interested in the tension between the kind of idiosyncratic, emotional, particular information or experience that goes into the relationship, and then the tension between that and how we scale that up. So AI is very much about that. And I want to tell you about I want to tell you first the scene I found when I interviewed many primary care physicians, and then 3 ways in which I think AI has something to offer to primary care, or the relationship in particular between doctor and patient. First, the scene. I think you'll recognize this. There is something of a perfect storm happening in medical care, and it involves this personal face-to-face relationship, which I actually call connective labor. Healthcare providers generally do not receive much training in relationship. Insurers and administrators do not measure it or reward it. And at the same time, physicians that I've spoken to are surprised by how much of their job involves connective labor. And in urban and rural areas, practitioners tell me that the need that they meet in hospitals and in clinics feels overwhelming. So for example, one physician said, "My patients, it's just like they're singing their song, their siren song, to whoever will listen, because no one will take care of them. They're just desperate." This kind of sense of being overwhelmed by what's out there. And yet practitioners are having to fit the feeding of these needs, these relational needs, into smaller and smaller increments while struggling to meet expanding demands of, say, the electronic health record, and other indicators of what we might call the data imperative. There's been a lot of work written about physician burnout and its relationship to data clicks and click fatigue and time pressures. So the reason why I'm saying that is that I'm kind of drawing for you a picture of what I would call or consider the degradation of connective labor. And against that landscape, we are welcoming, to some degree, the inroads of AI. So against this backdrop, AI offers 3 kinds of benefits to some degree. The first is AI as better than nothing. So one engineer talked to me, he said, there's a particularly disadvantaged population, and we think that by automating, we can greatly improve the care that they're getting. He's a Northeastern University scientist who, with his lab, created a virtual nurse, an exercise coach, a whole bunch of things, a palliative care consultant. These are all AI agents. So these are obviously halfway improvements for the underserved. And the first question is, are they good enough? In the case of the virtual nurse, 74% of the patients said that they liked getting their discharge information from the AI nurse better than the human provider. Here's a quote. I prefer Louise. They called her Louise. I prefer Louise. She's better than a doctor. She explains more, and doctors are always in a hurry. So research suggests that providers spend an average of 7 minutes with patients at discharge, while low literacy patients need close to an hour. However, the better than nothing argument assumes current staffing levels and compromises about quality are fixed and inevitable, and that the only way to relieve pressure on busy practitioners is to automate that work. And so there are two other questions that come up here. Are we relying on the technology to solve problems we're unwilling to address politically, change the inequality of access to personal face-to-face work? And the second is, are we kind of enabling the continuation of gross inequities in health? But second, sometimes AI is even better than nothing, particularly when we talk about shame. So fear of shame silences people who don't want to tell a clinician negative information, such as, say, drug use or domestic violence or a whole host of things. And providers tell me that they need relationships to establish trust so that people will tell them things that they're ashamed about. But engineers say, why make them feel shame in the first place? There's a lot of evidence that people are more honest with computers than they are with humans. They'll tell computers negative information about financial risks, or blood donors will confess to risky behavior, et cetera. So they will tell a computer that things they won't tell a human. So it could be that we're talking about two different kinds of secrets. The secrets that we know about, perhaps that would be fine to talk about with an automated provider in some way. The secrets that we don't necessarily admit to ourselves, we might need a human provider to walk us through that shame to get to a moment where it's out in the open to some degree. So there's a couple of questions that come up with this issue, like how do we know which is which? And also, but how can we be more deliberate about when we're using human care and when we're using some kind of automated system? So I interviewed one VA provider who had been tasked with administering a questionnaire to a vet with PTSD. And she talked about how that experience was horrific because she lost him. She knew the moment she lost him. And it was because she was kind of administering this survey under a compressed time period. And the lesson that I derived from this was, we need to not treat providers like computers. If he might have talked about his suicidal ideation, which was kind of the issue underlying it, if given the computer, or he might have talked about it with a human walking him through that. But the combination of the human under time pressure makes them more like a computer. It's not a deliberate use of human care. The third version I'm not going to talk about now. I'll talk about it in our conversation if we have time, which is the kind of impersonal nature of personalization of medicine, which kind of valorizes AI's capacity to drill down to the individual specificity. So the individual patient might feel seen by the machine. And the question I think we have to answer or contemplate is how we can have AI help the patient feel seen by the human, or help the provider see the patient rather than just have the machine. Thanks.
Great, thank you. Really glad to be here. This has been such an interesting discussion already. My name is Tess Posner, and I lead an organization called AI for All, and we're focused on increasing diversity and inclusion in the AI field. And we do that right now by educating and supporting underrepresented high school students in AI. And we also run mentorship programs and career development programs. But specifically, we have a summer camp in AI that is hosted at universities with a strong research focus on AI, including here at Stanford. And we have 5 other locations across North America. And we introduce young people who would otherwise be left out of this conversation entirely about what AI is, providing them with the technical exposure to it, but also introducing it in a human-centered context. How is this going to affect us? How is this going to affect different industries? And then giving them the chance to work on AI projects that are related to AI for social good. So our goal is really to increase diversity in the field, but also lift up stories and diverse role models to inspire others of what is possible with this technology, because it really is a tool that can be applied either to enhance outcomes for people and planet, or in more negative ways, of course. So when I'm thinking about a framework for inclusive AI in healthcare, I really think about 2 key things. The first is AI literacy. So we hear a lot from people that there's a lot of fear around AI. Those examples that you brought up are really interesting in terms of how people are interacting with it. But I think overall the media portrayal of AI is problematic in terms of who it's lifting up as an expert, the examples around it being dangerous or scary, and that kind of turns people off from wanting to interact with it. And I think it limits what we're able to do. So really needing to build AI literacy, not just among us in this room or people that are actually going to be working directly with AI, but also consumers, people that are receiving care, and understanding what is this all about? How is it different than a human? What are things that can go wrong potentially? What are your rights? How do you protect yourself? And so I think that education piece and AI literacy piece is critical. The second is diversity and inclusion, and really ensuring that from the beginning, as we're building these new solutions and innovations, that we're including people in the conversation that will be impacted from the start. And I think that's taking an interdisciplinary lens. I think this panel is actually a great example of that. But also bringing in communities that would otherwise not be part of the conversation from the very beginning. We launched with IEEE has an AI and ethics initiative. They're the largest association of professional engineers. And they have an AI and ethics initiative, and we launched with them the first ever youth committee to really try to get the young people's voice involved in creating ethical standards around the use of AI. And that's so critical because those young people are going to be the ones that will live with those decisions that we make today. So we need to involve them now, and many of them have already made, high school students that we work with have already made significant contributions to the field of AI. In fact, many of them are interested in the healthcare space. One of them recently won Best Paper Award at one of the largest AI conferences called NIPS last year for her work improving surgeon technique through machine learning. Another got funding from MIT to research methods for better diagnosis of dyslexia using computer vision. And so we have to support these young people in the conversation, but also other groups that may otherwise get left out will not only miss out on their potential contributions, their talent, their genius, their innovations, but also have major ethical risks if we exclude them from the conversation. Thank you.
Hi, everyone. I'm Mary Madden. I'm a research lead at the Data and Society Research Institute, which is based in New York City. And I'm so happy to have been part of this event today. It's been amazing. And I also share the perspective that I hope the future of AI medicine looks more like this panel. And I'm absolutely encouraged by efforts like yours to work with young people and to remember that really part of what is changing in terms of looking towards the future is that the people who are designing the tools that we're talking about are changing. And so I think that's incredibly important. So I'm also a zebra, like Allison, come from a social science background. And if you were to classify me into a cohort with an AI model, I'd probably be in Virginia Eubank's cohort. I do a lot of research looking at privacy, security, and digital inequality. I spent most of my career at the Pugh Research Center's Internet project, looking at the adoption and social impact of technology, particularly among youth. So I was there for 13 years. And towards the end of my time there, became the person who was tasked with leading all of the public opinion research post-Snowden, understanding how the Snowden revelations impacted Americans' attitudes towards privacy and technology. That then led me to apply for a grant from the Digital Trust Foundation, which was a temporary foundation, which I didn't know temporary foundations existed before applying for this, but it existed solely to distribute the settlement funds from the Facebook Beacon settlement. Beacon was that feature that would automatically send a story to your entire network every time you were logged into Amazon and Facebook at the same time and made a purchase. So if you say bought some underwear, everyone in your network got a post about that. Long story short, the money that came from that settlement was allocated for privacy-related research and education. The group that helped to develop the call for proposals was very forward-thinking. In particular, Chris Hufnagel, who's at UC Berkeley, not far from here, developed a call focused on understanding privacy and socioeconomic status, which at that point was really a very much under-researched and underexplored area, particularly from the perspective of policy. And so coming from Pugh, I had felt that that was an area that was ripe for opportunity. In general, people tend to talk about privacy issues in very sort of stark terms. And in the policy world, there are, I think, sort of many conversations that tend to represent very limited interests when making decisions about how our data is used. So that brought me to Data and Society. And then more recently, I've been doing work with Trenae Hawkins and her team, the Pioneer team at Robert Wood Johnson, to help them develop a new funding call to look at some of the unintended consequences of technology on health and well-being. We are sort of narrowing in on a focus on infrastructure, looking at not only technology's impact on physical infrastructure, but also data and technology-related infrastructure and human infrastructure. So how are all these sort of fundamental changes going to then have downstream impacts on access to health and well-being? And in particular, how are they going to have equity-related impacts? So that's what has brought me here. I just want to highlight a handful of themes and questions that came up today since we're the last panel, and I see that as part of our role, that I think are particularly important for us to leave here thinking about. I was really struck by Virginia's comments about how technology comes out of society and culture and goes back into society and culture. And I can't emphasize that enough and how important that is to bring to our sort of understanding and our creation of predictive models. We create these models in very controlled environments, sometimes forgetting sort of the historical perspective or forgetting some of the psychological factors that may influence, people's receptivity to a particular tool. And so something that my research has showed over and over is how much there is an overlap between low-income communities' digital privacy and security related concerns and their physical lived privacy and security concerns in their community. And it is impossible to completely separate the two. And so that's actually something that's quite promising, I think, about some of these more complex models is, again, representing a more complex perspective with understanding those multiple factors. At the same time, I think moving forward and thinking about what frameworks are going to allow for a more equitable future, I was trying to think of an acronym because I know, like, in general, in medicine, you guys like acronyms. And so I came up with OBV, as in, like, I think this is the obvious way forward, OBV. So for making AI more inclusive going forward, I think we need to think about inclusive observations, as in more inclusive data. And when I say inclusive, I mean not only who we are collecting data about, but how engaged they are in the process and shaping that research. I think that there are some real practical considerations there. Virginia brought up the issue of we need to make sure we have the funding to support the implementation of these tools in a way that's thoughtful. But also, I think we need to be willing to slow down the process. Like, good food is not fast food. We need to take the time to build these tools right. And being able to test them in synthetic environments is actually a really fascinating scenario to think about. So that's O, inclusive observations. For B, inclusive benefits. So making sure we design these tools, sort of saying up front, what are the benefits going to be to the participants? And will they see those benefits immediately or as soon as possible, not 50 years down the line? How can we make sure they are actually getting some benefit from their participation in this study, in this experiment? And then finally, the V is having an inclusive voice. How can we use these initiatives to elevate the voices of the people that these tools are impacting? And so we've heard from various speakers today who have done that in their presentations and elevating the voice. And I think it's just so important to tell those stories and to, again, make sure that we are representing the communities that we want to help in a way that removes that distance between sort of the designer and the patient at the end of the process. So that's all I'll say for now.
What was O again?
Oh, observations, inclusive observations.
No, because I want to tie, I want to talk about my work and how it ties to what you just said.
Right.
So my name is Timnit, and great music. I graduate. I got a PhD at Stanford in the AI lab, so I'm a researcher in AI. My specialty is something called computer vision, which is a subspecialty of AI. But last year, I've been focusing more and more starting towards the end of my PhD and afterwards about these issues of bias and fairness. And I've been working in a group called FATE, Fairness, Accountability, Transparency, and Ethics at Microsoft Research, right across the street from Data and Society. And I was at Data and Society at Virginia Eubank's book signing. And so my main focus in computer vision was how data mining, visual data mining, so gaining insights from visual data, and kind of the core computer vision tasks that arise as a result. And so you can imagine that there are a lot of ethical considerations when you're doing stuff like that, and there are a lot of issues of bias and fairness and transparency and accountability, et cetera, that come up. So during the course of my work, I noticed a few things. One is that I'm Black, and two is that there are no Black people basically in AI, especially technical ones. And so when I went to NIPS in 2016, there was an estimated number of 8,500 people, and I counted 6 Black people out of 8,500. And this is an international conference. And so internationally, I'll talk about the issues of classifying, racial classifications and stuff. If you look at Black in the way that is defined in the US, internationally, Black people are like 20%, almost 20% of the population, right? So 6 out of 8,500 is kind of a ridiculous number. I don't know how else to say it. So I co-founded a group called Black in AI, because we felt that it was very, very urgent, especially given the fact that we're discussing all of these issues that primarily affect people who have been historically marginalized, people who don't have the voices, people who are not participating, et cetera. So last year, and so since that group has been formed, many changes have happened, which is good. And so last year, let's say at this specific conference, we had about 200 Black people as opposed to 6, which is a great improvement. But again, 200 out of 8,500 is still kind of a very, very low bar. So that's one of the things I do. But that's not my main. That's like a side thing, not my main research. My research is more focused on how to, so besides the just core computer vision technical work, also focusing on how to address these issues of bias and fairness. So most recently, I had a paper with Joy Buolamwini, who is a researcher at MIT Media Lab, where she basically, I don't know, everyone I feel like has seen this video of her putting on a white mask to get computer vision systems, face recognition systems to detect her face. And so we decided to study this systematically and found that commercial gender classification APIs, so these are APIs where you pay for them, developers pay for them, and you show them a face, and they look at, basically they tell you whether it's male or female. Now there's lots of issues with that, just that task in general, but just looking at this very simple task, we found that these systems have, across the board, very, very high error rates for darker-skinned women. And so the darker you go, the higher the error rates are, and they almost approach random chance as the darker and darker you go. And so the good thing is that this research has been cited when people want to talk about policy changes and the ACLU and law enforcement and things like this. The flip side of it is some people are like, okay, why do we want to make this work better for darker-skinned women when we know that surveillance and all of this other stuff negatively impacts us? So this is a complicated question, which is why I have to also work on Black and AI to ensure that the voices of those who are negatively impacted is heard. In addition to that, I am in the executive committee of this is a plug, of a conference called Fairness, Accountability, and Transparency in Socio-Technical Systems. Dana is definitely very involved. And Dana from Data and Society, I know she's not Dana, but and one of the things we want to do, I'm just going to describe it a little bit because I think it would be of interest to this group and what we've been talking about, interdisciplinary work and things like this. One of the things we want to do is we want to bring different stakeholders together. So computer scientists, social scientists, people in law, et cetera. And one of the things I really like about this conference is, an example is that a tutorial that was organized by Christian Lum, who's a statistician at HRDAG, Human Rights Data Analysis Group. And this tutorial had, so it had a statistician, her, and it had a public defender, but the main person who was in this tutorial was Terrence, who was someone who was wrongfully convicted of a crime 2 times. First time he had to serve. And so, what's really crazy is that we keep on making the same mistakes over and over again. This is a whole group of people who are supposed to work on fairness, accountability, transparency, and you have social scientists and computer scientists, et cetera, and they're working on this, but they have never interacted with someone like Terrence. So they're working on a data set, the Compass data set, to minimize bias and so forth and so on, but they have never actually interacted with someone like him. They might have interacted with the ACLU, they might have interacted with other people. So this is one of the things we're trying to do differently in this conference, and I hope you all go check it out.
Perfect. Well, thank you. So I promised you guys a diverse panel, and I think we've really hit that. People looking at how we can bring AI into healthcare from all different perspectives. I love the comment on AI literacy, and I think it's so important that we bring in the diverse community and different people. We were talking about high school, but also it's clinicians. How are the clinicians using AI? How are our nurses and practitioners? How do we use AI to develop a framework to improve healthcare? So we've asked our panel, or throughout the day, we've talked about a lot of things, and we've asked our panelists to think about some of the topics that have been mentioned today. For example, we've talked about Flint, Michigan. We've talked about the opioid crisis, Black maternal mortality rates, and we've asked the panelists to think about, from their perspective, and thinking about the frameworks that they were just suggesting, how can we help the next crisis that's coming along? How can we use AI to think about the next Katrina, to think about these next public health epidemics that are going to come our way, and can we be better prepared for them? So again, I'm going to open it up to the panel, and everyone's looking down because nobody... And so I want you guys, if anybody would like to start the conversation on some of these topics we've talked about today and how you see the future moving forward using some of these frameworks.
I
Marinka,
can
you're
start.
sitting next to me,
I'm
so
not
sorry.
It's fine. Go ahead.
I can start.
Please.
So the topic that I was really quite passionate about is Black maternal mortality. In particular, I was thinking about it in the context of a research project that is actually going on here at Stanford, where we are looking at the entire cohort of babies born in California in the last 10 years, and really how those babies are transferred from one to the other hospital. So I will actually describe the role of AI through this example of this study. So the question in that study was to really model how patients, in that case babies, are transported from one hospital to the other. So imagine a baby is born in one hospital, and it often happens that the infant needs to be transferred to another hospital because there is some need for a surgery that cannot be performed in the originating hospital. So the question really then becomes, what's the hospital that baby should be transferred to? Sort of, imagine you're a doctor, you need to refer that patient to some other hospital. And originally I assumed that, well, and sort of that was also the assumption of the domain experts, that the way patients are transferred will mostly be determined by their medical factors. So their current clinical status, as well as the need in terms of what kind of surgery would they need and where are those surgeries performed well. It turns out that, unfortunately, that is really not the case. So we were very surprised by the fact that there are lots of non-medical factors, such as race, insurance, status of parents, that really were more indicative of what is the type of hospital that a particular patient will be transferred to. And sort of just as a small example, even beyond these covariates such as race and insurance that you would perhaps expect to be these kind of factors that might bias transport patterns, there were other very surprising things, such as a particular hospital in San Francisco preferentially was sending patients to a hospital in Berkeley. It turns out that might be the case. That is still our speculation, or that we are trying to resolve now, because lots of physicians got a degree at Berkeley. So they subconsciously were really biased towards sending patients somewhere where they know their colleagues are great and they perform great work. So where I see AI here is really as an excellent, wonderful tool that allow us to identify those potential biases and really examine them and in a systematic manner. Beyond a few obvious vectors that we always have in mind when somebody mentions bias or discrimination, there are also other really subconscious factors that are not intentional, but that often are really important and that can in fact improve the quality of care. Yeah.
Perfect.
Hi. So I was actually mortified when she asked me to figure out how my work relates to the topic of Flint and other things, and I thought, okay, great, I'm really pushing it here. But I actually thought of a very specific example that is still true. I mean, I think, again, quantifying expertise. So The example that I have is before I came here to Stanford 5 months ago, I was at the director of the Simulation Center at the University of Wisconsin, and we were the designated hospital for Ebola. Any patient in the state would be transferred or treated at University of Wisconsin in Madison. And in the Sim Center, we actually were responsible for training all persons that could potentially come in contact with the patient. Security, the triage nurse, the person in the parking lot, anyone along the way. And in the process of training, my staff and I, when we either participated in the training or observed, it was very clear to us that there were certain practitioners who in their own right, nurses and other people, other healthcare practitioners, may have been good in terms of taking care of patients in their own area, but when it came to this specific scenario, donning and doffing the protective gear, and then also partnering with a colleague to don and doff the protective gear safely, because that is the point at which a practitioner can contaminate themselves and you have the fear of death. You need the A-team. You want a practitioner who, if you think you've contaminated yourself, to tell you exactly what to do. It's eye to eye. And we observed people who didn't have the skill. We began frantically writing down names. We're like, oh my goodness, if I'm on the front lines, I want him. I want her. That person, oh my goodness, if they're gonna be we're all gonna die. I mean, and so we were, in that moment, we realized, how do we tell the chief medical officer how we came up with this list? We had no data, but we all saw the same thing. We've got to find a way to quantify it. And it's not just to say you're a good doctor, you're a bad. You're good in this circumstance. You're the one. Of course, not everybody wants to be on the Ebola team, but not everybody. There were people who were not afraid. They were confident in their skills. They were confident in their ability to partner and be on the A team. So I'm sticking to my guns. I think we've got to measure the experts.
Okay, given the choices, I wanted to talk about Black maternal mortality as well. I don't know who that is. I think that AI gives us an opportunity to think about how to be more deliberate about the use of humans for what they're good at, which is this connecting or relational work. So I think Black maternal mortality is a really good example of that, because to some degree, some of the story is about their experience of structural racism, which is, you could call it a kind of institutionalized blindness to their individuality, that they are continually misrecognized when they're in schools or in stores or at work for being, and they're feeling that misrecognition constantly as forms of microaggression. You could call stereotyping a form of misrecognition. And to the degree that that causes this kind of weathering hypothesis, this kind of stress on the body, you can imagine that being seen by a provider has a kind of really important, kind of human work. It does really important human work in terms of seeing that other person. And I just don't want that automated. I don't want that mechanized. I think the other two, the better than nothing that I outlined and the kind of freedom from shame, I think those are possibilities for AI in healthcare and using questionnaires on intake and all sorts of things. But my overall message or thought about this is that AI actually provides us an opportunity to think, well, here's where we can use automation, and here's where it's really important that we actually use people who are trained and who are good at connecting to another person in their individuality, and use that use the opportunity that AI gives to reapportion and value those connections. That's what I think.
Thank you.
I guess, yeah, I mean, I can add just going back to this idea of access and who has access to these tools. I mean, for any crisis that we're facing, we need creativity, we need innovation. And I think if we create more and wider access for some of these tools, we're going to have better solutions and more creativity. And I think we see examples of that just very organically. And again, speaking from just the youth that we work with, we've seen students coming up with these projects. So one student, for example, her grandmother passed away because the ambulance didn't arrive in time. And so she built a tool that routes 911 calls based on urgency using AI. And she hopes to someday deploy that in the wild. Another student grew up on a farm, and she's a daughter of farm workers, first-generation Mexican-American young woman. And she is using AI to track water quality issues. And that's something that has affected her community. So, I mean, there's so much evidence that if we bring more people in to provide them the tools, they're going to come up with solutions for problems that we may not even see yet. And so I think when we're thinking about prevention and also innovation and creativity and imagination, we have to think about who's involved and that we're going to maximize those things if we're inclusive from the beginning.
Yes, so yes, yes, and yes. Just nodding my head here throughout. So I wanted to address one of the scenarios that came up today and that we were prompted to think about, which is the potential use of AI in disaster response scenarios. And I think that's another case where you can see where the sort of better than nothing, emergency response is a very sort of desirable choice, right? The needs are so great and immediate. Some kind of care being distributed, some kind of assistance in the midst of chaos can be incredibly powerful. And so I wanted to just take a moment and then think about, on the one hand, what we might do in order to learn how, from past disaster response scenarios, how we might better distribute resources in the future, but then also to think about what are the limits of that that have nothing to do with AI. And so if we think, for instance, about Puerto Rico, which someone brought up earlier today, we now know that 4,600 people died. And we know that roughly a third of those deaths were attributable to either delayed or prevented medical care. And we know that it was an absolute failure of our country to respond to that crisis. And part of what enabled that failure to happen was the lack of a data and technology infrastructure, communications infrastructure that would be reliable. One of the presenters earlier today mentioned that staggering statistic that 2/3 of Americans living in US territories lack high-speed broadband access. And so I would just encourage us to really, every time that we're sort of thinking about how to deploy these tools in the wild at scale, that we take a moment to think about some of the basic infrastructure-related issues that are going to affect the deployment of those tools. But then also, when we have the best technology, but we have political leadership that refuses to acknowledge the existence of the need, how do we then enable, in our democracy, concerned citizens to learn how to develop the tools to respond, learn how to, even if it's just for their extended family, developing a mesh network for their extended family that lives in the remote mountains that still doesn't have reliable connectivity or communications networks, learning how to get their own drone delivery of some services. So I think there's some really interesting sort of community level applications and innovations when we democratize access to the skills and the tools needed to respond in those situations.
Yeah, I totally agree with the fact that the reason, one of the consequences of having such a homogeneous group of people working in AI is that the problem definitions are also very homogeneous and only are applicable to a certain group of people and only benefit a certain group of people. And even when they try to benefit other groups of people, it doesn't work. It reminds me of like international development, right? Like you have a whole panel of, stuff about Africa with no Africans. This is a pet peeve of mine. So anyway, but I wanted to actually address I wanted to talk about the quantifying expertise idea. I think this can be useful, but we really need to be very, very careful about how we do this kind of stuff using AI, because humans are very complex in the way, like you were saying, everybody could tell that so-and-so was the best person. And B, when you're doing this kind of automation in AI, it's done at scale. So one example I want to give is a company called HireVue. Has anybody heard of HireVue? HireVue is a company that automates, so instead of thousands of recruiters sifting through resumes, they automate this process, and so this process just automatically tells you who you should invite for an interview. So what HireVue says is that because humans are noisy, and this is an argument I've heard used by a lot of business school researchers at the business school, that many of the people who use HireVue ended up having a diverse group of people hired. But now imagine that there's some glitch in HireVue, like some bias or whatever. Now there is a possibility that I will be just completely non-hireable in every single job, right? Because HireVue is used by over 600 companies and all over the world. It's that scale. So when we're doing this kind of stuff with AI, we need to have standards. We need to have, kind of rules about where you can use it, what the characteristics need to be. There needs to be like an FDA type thing for these kinds of things. Because I would hate for some, doctor to be whose expertise is quantified a certain way by some algorithm now to just sort of be blacklisted from everywhere, right? So I guess that would be my final message.
Okay, well, thank you so much for joining us on the panel today. I think it's been a great, diverse talk. And so with that, I thank you all for coming.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.